Welcome everyone to this interesting lecture of Interventional Radiology supplies, in which we will explore the most important tools we use in intervention radiology for sake of making the procedures less invasive or minimally invasive. Today we're going to discuss one of the essential IR tool, which is guide wire. It is also essential to use guide wires along with angiographic catheters. Do you remember before when we took the biopsy gun and the coaxial needle? And we have mentioned that those tools are used together to do the biopsy. Likewise, with the angiographic catheter and guide wire, we use them together to do vascular interventions. These guide wires help navigate catheters through the blood vessels while minimize the trauma to vessel wall. Actually, we can classify guide wires according to the material, the coating, the flexibility, and the tip design. The first classification here based on core material. We have a stainless steel guide wire and we have nitinol guide wire. The stainless steel guide wire is rigid and with good torque control. It's like Amplatz wire. While the nitinol guide wire is flexible, kink resistant, commonly used in tortuous vessels like glide wire. Classification number 2 based on coating. We have hydrophilic guide wires and hydrophobic guide wires. The hydrophilic guide wires coated with a water-activated polymer for low friction and used for navigating the tight or tortuous vessels like thermoglide wire. While the hydrophobic guide wires are Teflon coated and they provide better tactile feedback and control. We use it in selective catheterization. Classification number 3 based on the tip type. We have straight tip, J-tip, angle tip. The straight tip guide wire used for general vascular access and straightforward vessel navigation. The J-tip guide wire reduce the risk of vessel trauma and help prevent accidental perforation. The angle tip guide wires used for crossing stenotic lesions or entering the branched vessels. Classification number 4 based on stiffness. We have soft guide wire and stiff guide wire. The soft guide wire used for initial access and atraumatic vessel entry, while the stiff guide wire provide extra support for large catheters and interventional devices like Amplatz super stiff wire. We have also different sizes of the guide wires, starting from 0.014 until 0.038. The smallest guide wire, 0.014, is used for coronary interventions, while the large one is used for large vessel interventions. In between, we have different sizes of guide wire for different procedures. Now let's come to the procedure details for vascular intervention. We will start by preparation as a standard before any procedure. As we know, we need to prepare our patient. We will check the informed consent, explain the procedure to the patient, check for any allergies, check for renal function because we will give contrast, establish IV access for sedation and fluids, shape and disinfect the access site like femoral or radial artery, administer local anesthesia at the puncture site. Number 2, the intervention radiologist will make vascular access through Seldinger technique. He will insert the needle into the artery, commonly femoral or radial artery, then confirm the blood return to ensure correct placement or confirm by ultrasound, then pass a guide wire through the needle into the blood vessel, then remove the needle, leaving the guide wire in place. Then advance a sheath introducer over the guide wire to maintain access. Then the intervention radiologist will select the appropriate angiographic catheter and he will insert it over the guide wire and advance it carefully into the target vessel under fluoroscopy. Once confirmed in position, he will remove the guide wire and connect the catheter to contrast media syringe, then inject the contrast under fluoroscopy to visualize the blood vessels. Then capture real-time X-ray images to assess the blood flow and detect abnormalities. Once we finish the target purpose of the procedure, then we will withdraw the catheter and apply manual pressure to the puncture site for 10 to 15 minutes to prevent bleeding. Then monitor the patient vital signs including the puncture site and the circulation. Keep the patient on bed rest for a few hours, especially if femoral access was used.